Good evening, my dear friends. And the topic which I am going to discuss now is on beta cell regeneration. I think this has been a long-standing dream for any diabetic patient. And to understand beta cell regeneration, I think we have to understand two more concepts. One is your beta cell differentiation, how exactly you say beta cell is formed. So beta cell differentiation, basically your pancreatic beta cells, they originate from your embryonic stem cell through a complex of cellular processes which is termed as differentiation. And this process basically involves very coordinated and tightly controlled activity where you have activation of certain gene clusters and repression of certain gene clusters. For example, when you try to look at your stem cell, next you have a definitive endodermal cells, then you have a pancreatic multipotent cells which can in turn differentiate either into ductal cells or your acinar cells, or which could again differentiate to pre-endocrine cells. Then you have a beta cell, alpha cell, delta and polypeptide cells. Now as they differentiate, what happens, many of these gene clusters are expressed and some of the gene clusters are repressed. So in de-differentiate, what happens, some of the gene clusters which are supposed to be repressed becomes expressed. So one, we should try to understand what is beta cell differentiation. Second, we should try to understand what is a beta cell dynamics. So the beta cell dynamics is basically a balance between your beta cell expansion and your beta cell loss. Your beta cells could expand or could multiply either by replication, or you can have a neogenesis where you can have new beta cells formed from a precursor cell which could be beta or non-beta cells. Your beta cells could hypertrophy, which is commonly seen in obesity or pregnancy, which could be a physiological increase in your beta cells. Your beta cell loss, initially we thought cell death or apoptosis is the beta cell loss, but sometimes what happens is your beta cell fails to function. Your differentiated beta cells becomes a beta cell de-differentiation. So these are the target of cell which could really help us in regenerating a beta cell. It is very difficult to regenerate a beta cell from a death or apoptotic cell, but it is definitely possible to make your de-differentiated cells to regenerate again. So with your basics of beta cell differentiation and beta cell dynamics, now let's try to understand why is that you have a type 2 diabetes, or what is the pathogenesis of diabetes mellitus. You have a glucose which acts on your beta cells to cause insulin secretion. When you have a insulin resistance, your beta cell compensates by secreting more and more of insulin. But as your beta cell dysfunction sets in, your beta cell is not able to compensate for the degree of hyperglycemia and you develop diabetes. And we thought once when your beta cell dysfunction sets in, it undergoes beta cell apoptosis. So your normal beta cells become a challenged beta cell, then it becomes a dysfunctional beta cell, and then it became a dead beta cell. So the change of beta cell mass in type 2 diabetes or type 2 diabetes beta cell apoptosis, which led to beta cell loss, could be related to hyperglycemia, what he calls glucotoxicity, which could be related to amyloid deposition, or which could be related to oxidative or endoplasmic reticulum stress, or your inflammatory cytokines, which again could destroy your beta cells. You can have a dysfunction or autophagy of the beta cell, you can have a lipotoxicity. There are several studies which have reported that the beta cell masses decrease to at least 30 to 50% in patients with diabetes. Now here is the catch. We know in type 2 diabetes or any diabetes to manifest, 90% or at least 80% of beta cell function has to be lost. But when you try to look at the beta cell mass, only 50% of the beta cell mass is lost. So which means there are still 30 to 40% of the beta cell mass is remaining, which is not functioning properly. Now these are the beta cells we are trying to target for a regeneration. Now when you try to look at your extended pathogenesis of your diabetes, so initially we thought beta cell apoptosis, but after the number 4 we see there is another path where you have loss of insulin content and mature beta cell identity. So your beta cell could de-differentiate, or your beta cell could have trans-differentiated to alpha cells or delta cells, or beta cells could have just degranulated, lost its identity and just simplicity. Now these set of beta cells you can try to manipulate or modify with a gene therapy, transcription factors or various pharmacological therapies. We know there has been some data in GLP-1 analogs which helps in beta cell regeneration. We have data on DP4. Now recently we had data on dapagliflozin also, which can cause beta cell regeneration. So we are trying to re-differentiate or regain this mature beta cell identity. Now having said this, what exactly is your beta cell dedifferentiation? We have seen what is beta cell differentiation before. Beta cell dedifferentiation is nothing but your mature beta cells, they lose to the various degrees their differentiated phenotype. So once when they lose their differentiated phenotype, they lose their cellular identity and they regress to a less differentiated or a precursor like state. So this concept of dedifferentiation has been proposed apart from cell death, which is going to contribute to your loss of functional beta cell mass, but still your beta cell mass is persisting. Now this is the beta cell mass which we are trying to improve. So the process involved in dedifferentiation is that, as I said before, there is down regulation of the beta cell enriched genes. There is upregulation of genes which are supposed to be suppressed in the primitive cells, and there is upregulation of progenitor cell genes. You have various genetic markers which suggest whether your beta cell could have regenerated or dedifferentiated. So ultimately what happens, this alteration or your phenotypic reconfiguration of beta cell ultimately results in defective insulin secretion and loss of beta cell identity. So when you try to represent the whole thing pictorially, you have a normal beta cell. In cellular stress, it becomes a dysfunctional beta cell, then it becomes a dedifferentiated, degranulated or transdifferentiated. So these are the pools of beta cell which are still viable but which are not able to secrete your insulin. So apart from your dedifferentiated transmitted beta cells which could be regenerated, the other possible mechanisms for beta cell regeneration: one, you try to improve the micro environment in which your beta cell is surviving. You try to reduce the inflammation, you try to use some immunomodulators. You can have in vitro regeneration protocols where you take pluripotent stem cells or stem cells which could be differentiated with the stimulus of ascorbic acid, zinc sulfate, GLP-1, various stimulators which could be done in vitro and then transplanted. You can regenerate it from the intrapancreatic cell, where you can regenerate your beta cell from a acinar cell, you can regenerate your beta cell from ductal cell, you can regenerate from exocrine progenitor cells. And you can also try to transdifferentiate alpha cells to beta cell and your delta cells to beta cell. So this is regeneration in intra-islet, regeneration in intrapancreas. You can also transdifferentiate your intestinal cells to have a beta cell, because all these things, they more or less have a common lineage of differentiation. So whether you have drugs, we have diabetic kinome inhibitors which are nothing but protein kinase that control and regulate protein functions involved in diabetes. And this kinome inhibitors has been tried in various illnesses, and one such is it has been shown to restore a beta cell. We have growth hormones, we have megainin, which again tries to regenerate beta cell. Of course, these are mostly in rodent models. We have very less data in human models. So other strategies to induce beta cell replication is that you have various cyclin D2, you increase a EZH2. There are senolytic therapies, you have glycolytic flux and glucokinase activators, adenosine kinase inhibitor, you can silence certain gene, you have hormone, you have serpentine, you have various drugs which has been studied not only in rodent models and also in human islets. We have data of human islets which are studied for beta cell regeneration with serpin B1 and other things. But in spite of so much data on beta cell replication, this regenerated beta cells should function properly. But we have lots of challenges in making the regenerated cells function properly. So you have various avenues to restore the function in regenerated beta cell. And one such hypothesis is that we are not able to balance the beta cell heterogeneity. What exactly is the beta cell heterogeneity? You try to look at various beta cell. When you try to stain your beta cell with insulin granules, some beta cells could stain high, some could stain medium, some could have a low. When you try to look at activity pattern in your beta cell, again you have various space setting. One beta cell could be a front runner, other beta cells could follow. You have various cell markers in beta cell which could vary, protein clusters. So unless you have a heterogeneous beta cell, the function is more efficient. When it is homogeneous, it may not function well. It's something like in a hospital, you have all specialists alone, your hospital may not function properly. You need a pool of, you need paramedical, everything to support. Similar way, if you lose your beta cell heterogeneity, it may not function adequately, though you are able to regenerate your beta cell. Second challenge in making the beta cell function is we are not able to balance the islet architecture. More than beta cell, your islet architecture is very, very important. Your blood supply, neuronal supply, where your alpha cell, delta cell, beta cell linkage is very important. We are not able to really restore these things. And you have problem in glucose sensing mechanisms. So all these things, though we are able to regenerate, we are still not able to conquer or make your regenerated beta cells function adequately. So this is my final slide. It is now established that impaired beta cell function in type 2 diabetes cannot be accounted for increased apoptosis alone. There are some dormant beta cells, or I would call hibernating beta cell, or dedifferentiated beta cell, which are still in your beta cell. Beta cell dedifferentiation may enable conversion towards other pancreatic endocrine phenotypes, and prevention of dedifferentiation or redifferentiation can be a potential therapeutic tool in regeneration. And this initial stages of diabetes is very, very critical in preserving the beta cell. What they say is within 6 years of onset of diabetes, your beta cell, you have still dedifferentiated beta cells which are alive, and if you are able to reduce your weight, control your blood sugar, there's all probability of regenerating your beta cell. There's nothing like regenerating your native cells. In artificial regeneration, then functioning becomes a problem. I think I'll stop with this, and thank you so much.